The following audio is part of a certified educational activity titled Optimizing Outcomes Throughout the Journey of Patients with Psoriatic Arthritis, a closer look at the importance of early diagnosis and role of new treatment options. Access the entire activity and complete the post-test at www.peerviewpress.com/GVR. Downloadable slides and practice aids are also available.
Today I want to tell you about the journey of a patient in my care who is living with psoriatic arthritis. Her name is Sue. Sue is 38 years old and is a well-respected biomolecular scientist running a well-funded lab with lots of postdocs. I always enjoy talking with her about her research during our office visits and admire the enthusiasm she has for her work. She developed psoriasis when she was 12 years old. Up to 40% of her body surface area was covered during the initial years of the illness, quite something for an adolescent. She had been treated for the psoriasis with topical steroid cream, UV light therapy, and methotrexate. At the age of 27, the first symptoms of psoriatic arthritis developed. She had asymmetric arthritis involving the wrist, knee, and ankle, as well as enthesitis, inflammation where her Achilles tendon and plantar fascia inserted into the heel, and dactylitis. She also had uveitis, a known extraarticular manifestation of psoriasis and PSA. She also suffered from fatigue, which made running a major lab extremely difficult, and functional disability. At work, she had difficulty pipetting, so it was lucky she had capable postdocs for this. She was also not able to go on long hikes, which was her favorite pastime. As you can imagine, all of these issues combined had caused a significant impact on Sue's mental well-being, and as a result, she was also suffering from depression. Psoriatic arthritis is a heterogeneous disease that includes involvement of skin, nails, peripheral and axial joints, and entheses. The variety of affected clinical domains makes the diagnosis and treatment of psoriatic arthritis challenging. Optimal patient management is dependent upon making the diagnosis early and accurately while assessing disease severity. An early diagnosis of PSA is a contributing factor to the achievement of good long-term clinical outcomes, as it allows for the potential to initiate treatment prior to the onset of significant and permanent joint damage. In the majority of patients with psoriatic arthritis, psoriasis symptoms precede development of arthritic signs and symptoms. In fact, it may take many years for a patient with psoriasis to develop inflammatory arthritis, as we saw with Sue, who first developed psoriatic arthritis 15 years after she was diagnosed with psoriasis. Therefore, dermatologists and primary care physicians must be able to identify psoriatic arthritis in patients with psoriasis who are at risk. Psoriatic arthritis screening tests are available to help accomplish this, such as the PEST, PACE, TOPAZ, or PASQ questionnaires. What are the clinical manifestations of psoriatic arthritis? Well, certainly current psoriasis, a personal or family history of psoriasis, dactylitis, or a totally swollen digit, as we saw with Sue, enthesitis, which is where inflammation occurs at the insertion of tendons or ligaments into bone, which we also saw in Sue's case, inflammatory spinal pain, nail dystrophy, juxta-articular new bone formation or periostitis, the so-called penicillin cup phenomenon based on osteolysis of distal joints in the fingers or toes, and usually the patients are rheumatoid factor negative. How do we differentiate psoriatic arthritis from rheumatoid arthritis? Psoriatic arthritis has a greater tendency for asymmetric and oligoarticular joint involvement than RA. Distal interphalangeal joints are commonly involved in psoriatic arthritis compared with rheumatoid arthritis. The spine can be involved in psoriatic arthritis, but not typically in RA. Enthesitis, dactylitis, and nail dystrophy are common in psoriatic arthritis and do not occur in rheumatoid arthritis. Many patients with RA are rheumatoid factor positive, while PSA patients are usually not. In contrast to rheumatoid arthritis, where the major focus of assessment is peripheral arthritis, psoriatic arthritis disease extent is also determined by the severity of extra-articular manifestations, including psoriasis, enthesitis, and dactylitis. The degree of involvement of the different domains of psoriatic arthritis, such as joints, skin and nails, and entheses, can vary significantly between patients, as well as over time within the same patient. But all of the domains may have a significant impact on the patient's quality of life. Therefore, a composite measure may be the most comprehensive approach to assess disease severity in psoriatic arthritis. What are some of the examples of new psoriatic arthritis-specific composite disease measures? These include the Minimal Disease Activity Criteria, or MDA, the CP-DI, the PASDAS, the GRACE measure, and the DAPSA measure. These are all being tested, and we'll see them being used more and more, both in clinical trials, but also potentially in clinical practice. It is also important to assess patients with psoriatic arthritis for the presence of comorbidities. These include the metabolic syndrome, which is characterized by central obesity, insulin resistance, dyslipidemia, and hypertension, cardiovascular disease, inflammatory bowel disease, uveitis, as Sue had, fatigue, as Sue had, fibromyalgia, and osteoporosis. What would be current treatment options for Sue once the diagnosis of PSA is established? Treatment of PSA requires consideration of both skin and musculoskeletal manifestations. Ideal treatment would be effective for both the psoriatic and arthritic components of the disease. Non-steroidals can be used in patients with minor joint involvement. They may relieve symptoms such as joint pain and swelling, but do not prevent development or slow the progression of joint erosions. Local steroid injections may be used along with non-steroidals. Oral steroids can be used, but should be used with caution in PSA due to the concern of exacerbating skin manifestations when tapering and risk for induction of pustular psoriasis. Topical treatments for psoriasis, such as steroid creams, can be used for milder skin disease. Then we come to systemic disease-modifying medications, and the first one we often use is methotrexate. This is usually first line as monotherapy or in combination with biologics. Evidence for efficacy is less well established than for rheumatoid arthritis. We know that it is associated with dose-limiting toxicity, and patients with risk factors for hepatic disease such as obesity and alcoholism may not be able to use methotrexate over the long term. Leflunomide has been shown to be effective in psoriatic arthritis. It too may have hepatic or GI side effects. Sulfasalazine is another oral medication that has shown modest efficacy in placebo-controlled trials. Some small studies only observed reductions in pain scores with no effect on radiographic progression. Adverse events include GI intolerance, reversible oligospermia, leukopenia, and agranulocytosis. Cyclosporin has been shown to be effective for skin manifestations of psoriasis, but it is minimally effective for joints. It should be used judiciously and briefly because it can induce renal toxicity and/or hypertension. TNF inhibitors have become a mainstay of treatment for psoriatic arthritis. These include etanercept, adalimumab, infliximab, golimumab, and certolizumab pegol. Etanercept, adalimumab, infliximab are also approved for rheumatoid arthritis, psoriasis, and ankylosing spondylitis. Golimumab and certolizumab are also approved for rheumatoid arthritis and ankylosing spondylitis. When Sue first started seeing me, she had already been treated with etanercept and adalimumab sequentially. Each were effective for several years, but then had waning efficacy. So, Sue and I decided to try another TNF inhibitor, certolizumab, which also worked well for a period of time and then began to wane in effectiveness. So we needed to decide upon another treatment. I was happy to be able to tell Sue there were several new options that had become available over the past few years. One of these, ustekinumab, is an anti-IL-12/23 agent, which was approved in 2013 for the treatment of psoriatic arthritis and is also very effective and approved for psoriasis. Apremilast, a phosphodiesterase 4 inhibitor, was approved for psoriatic arthritis treatment in 2014. It's an oral treatment option. It is also approved for psoriasis. Secukinumab is an anti-IL-17 agent. It was approved for psoriatic arthritis in 2016 and has been also approved for psoriasis and ankylosing spondylitis. There is a need for multiple medications and multiple mechanisms of action because some patients either do not respond or lose efficacy over time with these treatments, as we have seen with Sue. Secukinumab is the most recent addition to the PSA armamentarium based on phase 3 data showing efficacy in both TNF-naive and TNF-exposed patients. As with other effective medications in psoriatic arthritis, secukinumab showed efficacy in all key clinical domains of psoriatic arthritis, including skin. Targeting the IL-17 pathway has been an area of great interest because of our increased understanding about the central role of this pathway and Th17 cells in the pathogenesis of psoriasis and psoriatic arthritis. Ixekizumab is a second anti-IL-17A inhibitor, which was approved for psoriasis in 2016 and is under investigation for the treatment of psoriatic arthritis. Significantly more patients naive to biologic therapy treated with ixekizumab achieved an ACR20 response than placebo in phase 3 trials. All other clinical domains of psoriatic arthritis were improved with ixekizumab, including skin. These efficacy results were sustained through 1 year in studies. Ixekizumab has also been shown to be effective in patients with an inadequate response to TNF inhibitors. Brodalumab is an antibody targeting the IL-17 receptor and was approved for psoriasis in 2017. Further development of brodalumab in psoriatic arthritis is underway. Overall, the safety profile of IL-17 inhibitors has been shown to be relatively good, with a slight increase in infection, including Candida, in a small percentage of patients, which appears to be specifically related to IL-17 inhibition. Abatacept is a selective T-cell co-stimulation modulator. In a phase 3 trial of abatacept in psoriatic arthritis, this agent resulted in significant improvements in ACR20 responses and numerical improvements in HAQ response rates. The ACR20 benefits were observed regardless of TNF inhibitor exposure. The benefit on psoriatic lesions was modest. Efficacy was maintained or improved up to week 52. Abatacept was well tolerated with no new safety signals relative to the experience with this agent in rheumatoid arthritis. Tofacitinib, an oral Janus kinase inhibitor approved for rheumatoid arthritis, is also being investigated in psoriatic arthritis. Phase 3 studies have shown that this agent improves symptoms and decreases disease activity in patients with psoriatic arthritis who do not respond well to other treatments, including DMARDs and TNF inhibitors. So, with all of the treatment options for psoriatic arthritis, how do we choose? Treatment decisions in psoriatic arthritis are not always straightforward. Recommendations are available to assist in clinical decision-making. 2 sets of recommendations for the management of psoriatic arthritis were published in 2016 by international organizations: the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also known as GRAPPA, and the European League Against Rheumatism, known as EULAR. A 3rd set of psoriatic arthritis treatment recommendations will also be coming soon that were co-developed by the American College of Rheumatology and the National Psoriasis Foundation. The GRAPPA group has published treatment recommendations for psoriatic arthritis twice, the most recent being in 2016. These recommendations are based on a rigorous, systematic literature review and grading system of evidence. The recommendations are based on evidence in each of the clinical domains of psoriatic arthritis, including peripheral arthritis, skin disease, axial disease, enthesitis, dactylitis, and nails. For peripheral arthritis, the recommended starting point is NSAIDs and/or conventional synthetic DMARDs, except in those patients with severe disease or poor prognosis who may be considered for earlier use of a biologic or targeted synthetic treatment. For axial or enthesial disease, biologic DMARDs are recommended without need for prior use of a conventional synthetic DMARD. Recommendations for treatment of skin disease were generated by dermatologists within GRAPPA and include use of topical agents, conventional synthetic DMARDs, or biologic and targeted synthetic DMARDs in a sequential fashion and based on severity of disease. GRAPPA includes a number of overarching principles about management of the disease, including shared decision-making with the patient. GRAPPA has also included an extensive review of PSA comorbidities, as well as relative benefits and adverse effects of treatments relative to those comorbidities, and the importance of taking these in as contextual factors. EULAR recommendations include many of the same overarching principles and are overall very similar to the GRAPPA treatment recommendations. However, EULAR recommendations comprise a more sequential approach, encouraging early use of conventional synthetic DMARDs and then, depending upon outcome, biologic DMARDs in sequence. No clear preference for TNF inhibitors over other biologic agents is given in the GRAPPA recommendations, while EULAR lists TNF inhibitors as the preferred first-line biologic DMARD. Apremilast is only recommended by EULAR if biologic DMARDs are contraindicated, while GRAPPA recommends it alongside biologic DMARDs. As mentioned, it is very important that patients with PSA play an active role in decisions regarding their treatment. In order to make an informed, shared decision that is tailored to the patient's specific needs, preferences, and lifestyle, they must be educated about the various treatment options, including their route of administration, efficacy, and safety. Aligning PSA treatment strategies with patient preferences can optimize adherence, patient satisfaction, and ultimately outcomes. So I sat down with Sue and discussed these options, including the newer treatments with different mechanisms of action and how there was also an oral option, apremilast, in addition to the injectable treatments. I also discussed Sue's health status and the impact of the disease on her life and what was most important to her, as these issues also play a role in treatment selection. Sue had some very specific questions and concerns related to what could quickly and effectively get her back to being outdoors with her family, potential impact on childbearing, and also relative safety and tolerability. Sue took in everything I told her and decided she wanted to try a treatment with a different mechanism of action rather than a fourth TNF inhibitor. Sue liked the fact that secukinumab targets a molecule that is now known to play a key role in the pathogenesis of psoriasis and psoriatic arthritis, IL-17. So we initiated treatment with secukinumab. Optimal care for psoriatic arthritis takes into account the multidimensional nature of this disease. In particular, rheumatologists and dermatologists must have a close working relationship, which can be achieved regardless of whether you're in a combined clinic or not. In addition to the primary care physician, rheumatologist, and dermatologist, other healthcare providers should be part of the care team, including those focusing on cardiovascular disease, dietary and lifestyle modification, and physical therapy. For example, Sue is also seeing a mental health specialist due to the depression she was experiencing along with psoriasis and psoriatic arthritis, as well as an ophthalmologist to help keep her uveitis under control. So how is Sue doing now? She is doing well with secukinumab, most of the time in a state of minimal disease activity. She continues to successfully run her lab. She had one episode of pneumonia while being treated with secukinumab. We held the drug temporarily and used antibiotic therapy. She has rare flares of Achilles enthesitis, knee and finger arthritis. Her postdocs do pipetting for her when this happens, but is generally able to live life normally with no structural damage, deformities, or fatigue. She has not had recent recurrent uveitis and fortunately has not had vision loss. There is no evidence of active psoriasis. She is physically active and is able to go hiking regularly. She now has a 3-year-old daughter named Emma. I see Sue every 3 months to monitor her disease activity because, as I mentioned, some patients can lose efficacy over time, as Sue already experienced with other treatments in the past. Fortunately for Sue and other patients with psoriatic arthritis, there are many treatment classes with different mechanisms of action to choose from and multiple choices for many classes of treatment. And with a number of therapies in development for PSA, there may be even more options in the near future for Sue if by chance she does experience waning efficacy again. There is no telling where Sue would be without the numerous developments in psoriatic arthritis treatments. So, in conclusion, psoriatic arthritis is a potentially debilitating disease that must be identified early and accurately to prevent irreversible damage. Treatment options for psoriatic arthritis have expanded substantially in recent years and will likely continue to expand. Importantly, the management of psoriatic arthritis involves multiple specialties to address comorbidities, and treatment decisions must be made in conjunction with the patient. Thank you very much for listening to me talk about Sue's journey. I am glad I was able to share her story with you. I hope you found it interesting and can take what you have learned and use it when you care for your own patients with psoriatic arthritis.
Thank you for listening to this activity. Download materials and complete the post test for instant credit at www.peerviewpress.com/GVR. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.